Hello, everybody. I'm Ruth Delaney, a shoulder surgeon at Sports Surgery Clinic, and I'm going to talk about sports injuries and conditions that can affect the shoulder at various stages of life. A little bit about my background. I spent 6 years in Boston doing my orthopedic training, and most of that time was spent at this institution as a shoulder fellow. So in my last year of training, I got to spend some time in France, in Annecy and in Lyon, before coming back to Dublin in 2014. And my practice is exclusively focused on the shoulder. So shoulder pain is quite common. The majority of us are going to experience shoulder pain during our lives at some stage. And about a quarter of people who have shoulder pain report that they've had it before as well. So it can be a recurrent thing. And it can be quite debilitating in terms of sleep disturbance, in terms of affecting daily life and work. And it can come from a variety of different sources. It can be a little bit hard sometimes to figure out exactly where it's coming from. So that's where specialist comes in. I suppose talking about the shoulder and sports, the sport that I know the most about is tennis. And you can see why for example, a tennis serve, the shoulder is doing a lot of work. There are different phases of the serve. And one of the important things about sort of keeping the shoulder healthy when you're playing a sport like tennis is to remember that the shoulder isn't working in isolation. And so what's important is from the ground up. So everything is connected, and everything is part of what the physiotherapists and the strength and conditioning coaches will talk about as a kinetic chain. So if you have a good solid core strength, a stable base from your legs and core, then your shoulder is going to be that bit more protected when you're doing things like playing tennis or swinging a golf club. The shoulder blade is also really important, because that's a stable platform for the shoulder to function. And if you think about the shoulder as a ball and socket, with the socket relatively small and the ball having a lot of freedom of movement, it's got to have a stable platform to work off. And the socket of the shoulder joint is part of the shoulder blade. And that's why when we send you to physiotherapy for your shoulder, the physio will often spend a lot of time working on your shoulder blade control and getting all those smaller muscles around the shoulder blade to work, because they often go to sleep, particularly when the shoulder is sore. And a lot of times when we go to the gym, we train the bigger muscles and we forget about those small but really important muscles around the shoulder blade. When the shoulder blade isn't really working well with the rest of the shoulder, it's something that we call scapular dyskinesis, which is a broad term that just means kind of that the shoulder blade is out of rhythm. And that, in people who play overhead sports, can increase the risk of shoulder pain. So again, going back to, for example, a tennis serve. So things that are going on with the foot position or with the knee bend can affect how the shoulder ends up having to compensate and lead to problems with shoulder pain. The same thing with hip flexibility, with the trunk and the core strength. And as we talked about, the shoulder blade or scapula, so that scapular position, all can feed into what happens when you try to go through the motion of a serve. And a lot of us are stiff through, for example, the thoracic spine, or that part of your spine in between your shoulder blades. And again, that can have an effect on how your shoulder works. So when you're playing a sport that involves the shoulder having to do something, there's a lot more going on that often needs to be addressed when your shoulder is sore. Playing golf, not strictly considered an overhead sport, but when you're at the extreme peak positions of a golf swing, those positions can provoke shoulder pain. So abduction is bringing your arm away from your body. Adduction is the opposite, bringing it across your body. And you can imagine that there are parts of a golf swing at times that will be in the maximal extremes of those positions. And when you bring your arm away from your body, sometimes you can end up with something called impingement, or when the ball and socket is up like this, the ball is up like this. We've got the roof of the shoulder over top here, or what we call the acromion. You can get some pain from inflammation under there. When your arm is across your body or in adduction, that can, particularly in younger golfers, and we see it in hurlers as well, with a similar position of the shoulder, that can sometimes leave the shoulder vulnerable to a less common type of instability, which is out the back or posterior instability. The biceps is an interesting muscle that has two tendons at the top end, and one of those, the longer one, goes right through the shoulder joint. And repetitive motions like a golf swing can irritate that tendon, leading to tendonitis in there. And that's something that we see commonly in people involved in many different sports. The nice thing about a sport like golf, while it can place demands on the shoulder, we usually see that people are very well able to get back to playing golf and pretty much at the same level as they played before, even when we do pretty complex shoulder surgeries, for example, repairing rotator cuff tendons or replacing the whole joint. Collision sports, a little different. The most common injury we see in people who play things like Gaelic football, rugby, hurling is instability or dislocating the shoulder. And the more common type of that is the shoulder dislocating out the front. So the ball and socket joint, ball comes out the front of the socket. And the reason that the shoulder is susceptible to that is that the socket is relatively shallow as well as being small. That's what allows us to have so much movement of the shoulder. But in certain positions, particularly, for example, with the arm overhead, the shoulder can be vulnerable to instability. And if you dislocate your shoulder for the first time at an age under 25, there's a very high risk of it happening again. As you get a little older than 25, so people in their 30s and 40s who dislocate their shoulder for the first time, those people have a much lower risk of it becoming a recurrent problem. Sometimes you can have other injuries that happen with it, which are more common in people over 40, for example, tearing rotator cuff tendons. But the likelihood of the instability having to be addressed is much lower. In these younger players, often we end up looking at surgery to stabilize the shoulder, and there can be, broadly speaking, two types of surgery. One is a soft tissue surgery where we fix the soft tissue surgeries or the cartilage bumper around the shoulder socket called the labrum. And the other one is where there's more severe damage to the shoulder, often in cases of multiple dislocations where we have to actually put a bone block on the front of the socket to stabilize it. And after those surgeries, the rehabilitation time varies. It depends on the type of surgery. It depends on the sport that the player wants to get back to, but the quickest would be typically about 3 months. And it can often, particularly in the soft tissue surgeries, take 6 months for the shoulder to be ready for the high demands of collision sport, because those are probably the riskiest sports for the shoulder joint. So if we think about the types of symptoms that people typically get in the shoulder can be sore, it can be weak, it can be unstable, like we've just spoken about, or it can be stiff. And these are not mutually exclusive. Obviously, a shoulder can be sore and weak at the same time. And the other thing that we often think about as well, and it's important not to forget, is that a problem in the neck, so in the cervical spine, can present as shoulder pain or weakness around the shoulder. And equally, a problem in the shoulder can give you some neck pain. A lot of people have both going on at the same time. So it can sometimes take a while between the spine specialist and the shoulder surgeon to figure out between us, okay, where's most of the pain coming from? Which should we tackle first? Or often we tackle the two things in parallel. Sometimes injections might be part of that, because as well as helping the inflammation and hopefully making your pain or symptoms better, they also give us good diagnostic information. If an injection into the neck does nothing for your shoulder symptoms, but an injection into the shoulder helps your shoulder a lot, then obviously the pain is coming more so from the shoulder, and we prioritize taking care of the shoulder. So the kind of diagnostic workup of shoulder symptoms can often be complex. And so the history that you as the patient give us is something that we learn a lot from, because there are typical patterns of symptoms for some things and typical stories. And that's where the questions come from that we often ask people presenting with shoulder problems. We get a lot of information from actually examining the shoulder. And during the height of the COVID pandemic, when we were doing video consultations and trying to figure things out without being able to actually hands-on examine people, I think that really made a difference with shoulders. It was a little harder to figure things out sometimes. And then imaging will often play a part too. Plain x-rays are very good for certain shoulder conditions and sometimes are better than MRIs. For example, if you have tendonitis in your rotator cuff and there's some calcium in it, or what we call calcific tendonitis, we can see that much better on an x-ray than on an MRI. We can see bones much better on an x-ray than on an MRI. So if you have a shoulder fracture, or if you have shoulder arthritis where you want to see the bones and the shape of them, an x-ray will often help us more so than an MRI. The MRI helps us a lot for soft tissues. So if you have a weak shoulder and we're not sure if there's a torn tendon, that's when we might look for an MRI. Or if there's an unstable shoulder, we might get a special type of MRI with dye in the shoulder, which will outline the structures that get injured in instability. And sometimes we need other studies too. For example, a CT scan is sometimes useful for certain situations as well. So which imaging is best depends on what we're thinking the problem is. And sometimes we need more than one type of image. Some of the most common shoulder diagnoses that we see are the rotator cuff problems, a frozen shoulder, which I'll explain in a few minutes, arthritis of the shoulder, and instability. Of course, there are many other shoulder injuries that can also present, particularly in the context of sport, things like broken collarbones, AC joint, or the joint at the end of your collarbone getting injured during sports or fall. But I think these four are probably the most common that we see. So if you have an injury and you end up getting to the point where it's an injury that's appropriate for surgery and you're considering shoulder surgery, I think it's important to get advice from a shoulder specialist. There's a lot of misinformation out there. Of course, there's Google and all of that, but even sometimes within the medical community, because the field of shoulder surgery and shoulder care is evolving so fast, that unless it's a shoulder specialist you're talking to, you may not be getting the most up-to-date advice or the appropriate advice specific to your individual condition. And anytime we talk about surgery, it's always a risk-benefit balance. Any surgery will have risks. Even the smallest surgeries we do, even the more minor keyhole surgeries, there will be a small risk of infection, a small risk of stiffness, a small risk of pain not resolving. And while those problems are very uncommon, if they happen to you, then that's something that, you know, is really a tough problem and can mean your recovery takes longer. So the benefits, the potential benefits of the surgery have to be bigger than those risks, which are rare and small, but can be a problem. So typically when we offer somebody surgery, it's because we can see that their particular problem will benefit a lot from the surgery and far outweighs any of the potential risks with surgery. And sometimes that's a trickier balance. And a lot of times that will be an individual decision for the patient and something that we discuss with you and try and arrive at the decision together. The other thing about surgery is the recovery is important to think about, and the rehabilitation time. Some shoulder surgeries take quite a while to recover from, and the rehabilitation is quite intense, and that's important to know beforehand and feed into your decision. And preparation is important. That's our job, to help you prepare and tell you what to expect and explain the surgery. And we use our website to help with that and help make information easily accessible as well, so that I explain what shoulder surgery at SSC under my care involves. And I think that's useful for a lot of people to be able to go back over that, because it's hard to remember everything if you come see us in the office and we explain something. So it's nice to have a resource to go back to. The other part of surgery that I think is really important is that we measure how you do. So there's no point in doing surgeries and not following up how people do in the end and keeping that follow-up out as long as possible. This is a picture of Ernest Amory Codman, who was one of the first shoulder surgeons back in the early 1900s at Massachusetts General Hospital. And he, in fact, was pushed out of that hospital for daring to suggest that surgeons should measure their outcomes and report them and record them. And now, over 100 years later, that's one of the central principles of taking care of patients as surgeons, that we actually measure how you do so that we know, was that the appropriate procedure for that condition? Are there ways we can do it better? If this person did really great, then was there something about them or their condition or how their surgery was done that we can replicate? And so we use this email-based system called Surgical Outcome Systems, which sends the patient an email before surgery asking you a few questions about your shoulder's current status, so that we have kind of a baseline. And in that graph that you can see on that slide there, it's a pain score graph. And it maps that particular patient against a global average, against the average for my practice, against the average for the hospital. So we can see this particular patient whose line is in red is doing better than average, their pain score is lower. And it sends out surveys at regular intervals after surgery as well to track progress. And I think that's really helpful for both the patient and the surgeon. So to go back to these main diagnoses and go through each of these sort of broad groups. So you hear a lot about the rotator cuff, and it's hard to conceptualize that if you don't actually see some pictures and have a good explanation of what it is. So the rotator cuff is a group of 4 muscles that are deep inside the shoulder, attached to the shoulder blade, and then they sort of coalesce and form a cuff, if you like, of tendons, which is that white part you can see on the picture around the humerus. So on the right side is the front view and on the left side is the back view. And so those 4 muscles and their attached tendons make up the rotator cuff. And they can be involved in various different processes in the shoulder that cause pain. They don't have a great blood supply, so they do undergo normal wear over time. And sometimes in the context of that wear, the tendons can get inflamed. Sometimes they can get inflamed just with repetitive use and cause some inflammation around them in that space. And that's one of the common things that we see. The tendons are still intact, but they're sore and causing pain. Other times the tendons can actually tear, and that can be a gradual thing where the wear has just gotten to the point where a little bit of the tendon detaches. And then sometimes the tendon can tear with a sudden trauma, like a fall. And the tears come in various different shapes and sizes, and how we manage the tear depends to a large extent on the size of the tear and also on the age of the patient. So there can be many different ways to handle it. You will almost always see some abnormality in the rotator cuff in an MRI in anybody over the age of, say, 25 or 30, because normal wear over time will show up on the MRIs. And our MRIs these days are very sensitive. They're very advanced technologically, but sometimes that can be a bad thing, because then you see a whole load of things on an MRI report. And unless you're a shoulder specialist examining the shoulder, it can be very, very hard to figure out, okay, which bits of this big long report actually matter, which bits tie in with the shoulder pain, and which bits might actually be the same if my other shoulder, which has no pain, was also scanned. The inflammation that I talked about, or bursitis or tendonitis, will often respond to physiotherapy and working on the shoulder blade control. Sometimes we'll add an injection into that space over the tendons, and that can be very effective. Occasionally, we might do a keyhole surgery to clean out the inflammation, but it's rare to need surgery for the inflammation. When there's actually a full thickness tear, as opposed to the sort of wear or what might be described as partial tears, the full thickness tear management depends on whether the shoulder is compensating well, or whether we can teach the shoulder to compensate well with physiotherapy. It depends on how large the tear is. In the larger tears, so for us, that would be something like 3 centimeters or more, which is the distance the tendon is pulled back from its attachment to the bone. Those tears are at risk of getting bigger, getting worse, causing more problems. And they're the ones we'll often recommend surgery for. However, in patients over the age of 70, the healing rates are variable. And sometimes you can see that those patients do just as well with an injection and physiotherapy to compensate. And so it's a very individual decision. The other side of that is that if a tear is larger and gets bigger to the point where it's not fixable, ironically, you have more options in a slightly older age group, because we have options with shoulder replacements to compensate if the tear were to get bigger. Those weren't really designed to be used by younger people or to last as long. And so in a funny way, you have more options with rotator cuff tears sometimes in people over 65 or 70. So again, it's a very individual decision. If it's something that we do decide together we want to repair, in my hands, that will almost always, well, 100% of the time really, be done arthroscopically or keyhole. So with a camera inside the shoulder and little small incisions, multiple portals inside the shoulder that allow us to essentially stitch the tendon back to the bone. And the way we do this is by using anchors that are typically plastic, and those screw into the bone and allow us to attach the tendon. It takes time because, as I said before, that rotator cuff doesn't have a great blood supply. And so the healing takes time. Recovery involves being in a shoulder immobilizer for the first 4 weeks. If it's a very large tear, we may use it for 6 weeks. And we would start with some very gentle exercises. You can't drive while you're in the sling. So typically people are 4 to 6 weeks away from driving. And physiotherapy is key. Range of motion or stretching is the most important part at the beginning, and we don't have the physios do any strengthening or weights or resistance bands until about 3 months, because the tendon fibers have not healed enough to take any resistance by that stage. So it typically takes about 6 months to get over a rotator cuff repair. Obviously, you can do a little bit more as time goes on during that 6 months, but I think it's really important to get your head around the fact that it is not a quick fix if this is a surgery that you're looking at. To move on to something else in the shoulder, frozen shoulder is something that seems to be very common. And it is something that we don't understand exactly why it happens. Its other name is adhesive capsulitis. So it's an inflammation of the capsule of the shoulder. So the lining around the ball and socket or the joint capsule gets inflamed, often for no good reason. More common in women. Typical age group would be 40s and 50s. There are associations with hormonal changes like menopause, diabetes, thyroid, but it can affect anyone. We see it often in people who have none of those risk factors. And what happens is that the capsule gets inflamed and the shoulder can get quite painful. And in the early stages, it hasn't gotten obviously stiff. So sometimes the diagnosis is not clear in the beginning. As that capsule gets more inflamed and thicker, the shoulder gets tight and stiff, and it becomes difficult to move. And that can be a really difficult problem to have. You have a very sore shoulder that's stiff, and it feels pretty miserable. Thankfully, most of these cases resolve without surgery. The capsule is inflamed, so if we use anti-inflammatory strategies, those are typically very effective. So anti-inflammatories that are not steroids, things like Nurofen or other drugs from that group. Sometimes we do use steroids. So cortisone injections can be very effective, but it's important as to where they're put. Sometimes the injections that are done by people who are not so familiar with the shoulder might be put into that space above the rotator cuff tendons, because that's one of the most common places to have a shoulder problem that can respond to an injection. However, with frozen shoulder, the main ball and socket joint, so underneath the tendons and between the ball and socket of the shoulder joint, is what needs to be injected. So sometimes we see people who haven't responded to injections who have frozen shoulder, but it's that the injection maybe wasn't quite in the main joint. And steroid tablets we'll use sometimes if somebody's having a lot of pain, just for a short course, maybe a week. And we're very gentle with these angry frozen shoulders, just gentle stretching. Sometimes physio is too much. Somebody else trying to push the shoulder tends to aggravate it. So we just do a gentle stretching program at home that you follow some videos. Getting into the pool can really help to do some gentle stretches. And most cases, I would say more than 90% of cases, resolve without needing an operation. These are some of the stretches that we use and the exercises in the pool. And if the symptoms are not resolving in that small number of cases, we would consider surgery. And that's a keyhole surgery again, where we release that capsule. And the anesthetist also typically will give a nerve block as well as providing general anesthetic. And the nerve block means that after you wake up from the capsular release, the local anesthetic around the nerves to your arm has completely numbed the shoulder and the rest of the arm. Unfortunately, it's not possible to do that without also turning off the muscles, but it means the arm is nice and loose. And while it's a strange sensation, it does facilitate immediate physiotherapy for stretching. It tends to wear off after 18 to 24 hours, but in that first 18 to 24 hours, it means we can have the physiotherapists do a lot of stretching with the shoulder after releasing it. So unlike when we're trying to treat frozen shoulder without surgery, when we're treating it with surgery, we want to really get aggressive and moving and stretching, because the first thing that capsule wants to do after we release it is to scar back in. And so what we do in the surgery is to release that thickened, inflamed capsule. And we do use the physiotherapist intensively afterwards. And that's what that looks like on the inside. The camera is in the back of the shoulder. The ball or the head of the humerus is on the left in that picture over on the left. And the far right, it's at the opposite shoulder. The ball is on the right socket on the left. But what you're seeing in the middle is that red, angry, soft tissue. It doesn't normally look like that. That's the capsule. And we're using a radio frequency probe to divide it. And it's really amazing. When you have somebody with a frozen shoulder, even under anesthesia, fast asleep under general anesthetic, the shoulder doesn't move because it's mechanically limited by this thickened capsule. Once you release it, you can see full movement straight away. The challenging part is once the patient's awake, there's muscle tones, there's a bit of discomfort, and maintaining that range of motion is where the physio comes in. To talk about shoulder arthritis, I think it's really worth mentioning this because people don't tend to hear about it as much as hip and knee arthritis. So it's cartilage wear of the main shoulder joint. So again, the ball and socket joint. The AC joint, which is up at the top between where it says clavicle there and acromion, so clavicle being your collarbone and acromion being the point of your shoulder, that little joint up there is not your main shoulder joint. And almost every single MRI will show some wear of that joint. And so you may see the word arthritis in an MRI report. But if it's talking about the AC or acromioclavicular joint, then that's not really shoulder arthritis. Most of the time, that doesn't even hurt. Sometimes that wear can get inflamed. And if you have pain when somebody presses right on that spot at the top of your shoulder, then we may treat that with an injection. That's not the type of actual shoulder arthritis that we're talking about here, though. We're talking about the main ball and socket joint, which looks a little bit like a hip, getting worn out. The cartilage surface of that getting worn, and the space between the ball and socket therefore getting smaller, and mechanically it becomes much more difficult to move the shoulder. There can be a lot of pain due to inflammation associated with the arthritis. So on an x-ray, you'll see on the left there's a round head of the humerus or ball in the joint and a normal joint space. On the right there's arthritis, so it's become irregular. The body can't make new cartilage once it wears away. It tries to redistribute the load and create extra bone. So we get these bony outgrowths called osteophytes, which get in the way of moving, and there's no space in the joint anymore. And that can be really painful and stiff. So there are different ways that we can treat this, similar to arthritis in the hip or the knee. Pain relief, Physiotherapy sometimes can help. Some people find it doesn't help their arthritis, so we tend to just try it out. If it's not helping, then we don't push it. Injections can help. They won't change the underlying arthritis, but they can take down the inflammation associated with it, which sometimes helps with the pain. So cortisone can do that. There are other injections which are sort of like a gel that mimics the joint fluid. We call them viscosupplementation injections. Sometimes they work for some people. In people with milder stages of arthritis, something called PRP or platelet-rich plasma can sometimes give pain relief. And so there are various things we can try before considering surgery. In some cases, in a younger patient with milder arthritis, we might consider a keyhole surgery to clean it out. Again, we're not going to affect the underlying arthritis, but we may buy some time and get some pain relief. Ultimately, the most definitive way to treat shoulder arthritis is to replace the joint. The implants, where we replace the joint with metal and plastic, just like in a hip. The longevity of those implants can be affected by heavy use of the shoulders or high impact activities, but a lot of sporting and recreation activities are just fine. Things like golf, swimming, tennis, yoga, all of those are well tolerated by a shoulder replacement. This is one of the situations where we do get a CT scan because we see the bones much better on a CT than on any other type of scan. And that allows us to actually plan your shoulder replacement in a very individualized way, where we can figure out exactly what shape your socket is and which implants are going to fit you best. This is an example of quite a famous tennis player from many years ago who then was playing on the seniors circuit and regained his world ranking after having a full shoulder replacement. So it's absolutely possible to go back to recreational activities, and oftentimes it's easier to go back because you don't have the pain from your shoulder arthritis. This is what a total shoulder replacement looks like. So instead of the native ball and socket, we've put a white plastic socket in there and a metal ball, and there are various different shapes of implant depending on the problem and the patient's size. There's also something called a reverse shoulder replacement, and you can see if we go back in the anatomic or primary total shoulder, the ball and socket are right where they used to be in the native shoulder. But we can also put the ball and socket the other way around. And the reasons that we might do this are if the rotator cuff was torn as well as having shoulder arthritis, the regular or anatomic shoulder replacement will not work unless there are intact rotator cuff tendons around it. And this was a real problem up until a French man named Paul Gramont discovered that reversing the geometry of the shoulder allowed the shoulder replacement to work without rotator cuff tendons. So now if you have shoulder arthritis and a rotator cuff tear that isn't fixable, you can still have a shoulder replacement. It's just going to be a reverse shoulder replacement. Similarly, if there's an awful lot of wear of the socket of the shoulder from the arthritis, we can't use the regular socket, the plastic socket that goes in an anatomic replacement, but the reverse shoulder replacement can handle that problem. Sometimes we even end up doing a reverse shoulder replacement for a very large rotator cuff tear where the shoulder is not functioning anymore, even if there isn't arthritis. So if the rotator cuff tear, the tendon tear, is too big to fix and the patient has trouble raising their arm, if we reverse the ball and socket by doing this, we can allow the big deltoid muscle on the outside of the arm to actually take over the job of raising the arm. Obviously, this isn't really meant for younger people. We know it lasts pretty well for probably about 15 to 20 years. So we don't want to be putting it in a 40-year-old, but that's what I mean when we say that you probably have more options when you have a bigger rotator cuff tear at age 60 or 70 than you do when you're younger. So there are many things that we can do to help those problems. What's involved in a shoulder replacement? They're done under general anesthetic. Most people would spend about 2 nights in the hospital, 4 weeks in that same shoulder immobilizer. So again, you can't drive for that first 4 weeks. People with shoulder arthritis often find that the pain relief is dramatic even in the first few days. Despite the fact that we've just done a pretty significant surgery, the surgery pain is nothing compared to what the arthritis pain has been for all those years. And so often the pain relief is really very good early on. Everybody's a little different, and some people have a little different timeline to others. Again, physiotherapy works on regaining motion and then strengthening. Usually takes about 6 months to work through the rehab program, and people tend to keep making improvements up to about a year. But in terms of going back to recreation after replacement, it depends on exactly what the activity is, but golf is probably 4 or 5 months, swimming maybe a little bit earlier, tennis probably closer to 6 months. This is what we do with the CT scan that we have you go get before your shoulder replacement. It shows us in great detail the measurements and the angles, particularly about the socket of your shoulder. And we can even order a model of the socket of your shoulder and a guide that helps us in surgery position the implants exactly where we planned on the software. So it's a way of doing the surgery on the computer before we do it in you. It's trial without error. It's sort of like a flight plan for a pilot. It's the same. So pre-op planning is really important. And something we've been able to introduce within the past year is using mixed reality, which is where you overlay a virtual reality hologram of that patient's individual shoulder and the shape of their socket and the guide over the real environment when you're operating by wearing this Microsoft HoloLens, which is what I'm doing in the picture on the right. And that improves our accuracy in implanting the shoulder replacement. So there are a lot of exciting things happening around the field of shoulder surgery, particularly shoulder replacements. So the benefits of staying active overall in terms of the shoulder and in the body in general will usually outweigh any wear and tear issues that may come along. And the shoulder is susceptible to wear and tear for all the reasons that we've spoken about before. I think doing simple things to preserve your shoulder joint longevity when you play sports are worthwhile. So thinking about that kinetic chain. So if you have some weakness in your core or in your hips or knees, that may affect your shoulder, especially playing things like golf or tennis. Also playing collision sports, the kinetic chain is equally important. And that's why the strength and conditioning training all feeds in. Footwork is important. So for example, sports such as tennis, you need to work on getting as close to the ball as you need to, so you're not overextending your shoulder. Your tennis coach can help work on all of that aspect of the game. And so technique comes into it a lot in terms of protecting the shoulder when you play sport. And then having the right gear, be that for the weather, the footwear, all of those things protect your body, and in particular can help protect the shoulder in some of the sports that place demands on the shoulder. So that's it in terms of my slides. I'd be more than happy to answer some questions afterwards. Thank you.
Thanks, Ruth. Really interesting talk. So we've got a load of questions coming in. So we'll start with one. What's the cutoff age for a shoulder replacement? And this lady's mother's 82, maker, and she had her left shoulder done 5 years ago. So it's the right shoulder now.
Mm-hmm. I suppose rather than the age as a number, we look at the whole picture. And so if somebody is of a certain age, but in pretty good condition medically, it's often possible to go ahead. I would always defer to the anaesthetists and our pre-op assessment clinic. So, that particular person has a pacemaker, is on warfarin. Those things don't prevent us from doing surgery. There are some challenges in terms of the warfarin being a blood thinner, making sure we talk to their cardiologist or whoever is in charge of that we have an alternative way around that to prevent too much bleeding in surgery, but also keep them, their blood the way it needs to be for whatever they're on the warfarin for. So I don't think that we would write someone off and say they can't have it. If they're having an awful lot of pain and other things aren't working, like medication, injections, sometimes the pain specialist can do nerve blocks, so there are other ways if someone truly is medically unfit for the operation and the anesthetic, but we don't have a specific age cutoff. I've certainly done it for people in their 90s, but that's where the pre-op assessment clinic really comes in, very important.
Lovely, thank you. So another question here from Anne English. She was diagnosed with frozen shoulder 12 months ago. Now she has a steroid injection here, actually an SSC, but she still has pain. Her movement is much better. She said, is there any advice that would help her to move?
I think if it's unusual with frozen shoulder for the movement to get better and the pain still to be there.
Right.
So I would wonder if there's something else going on, that maybe there was a frozen shoulder and that's now sort of settled down, that capsular inflammation is gone, but there's still pain for a different reason. Because the usual progression with frozen shoulder is that the pain settles first and the movement takes a bit longer. So normally it's only kind of when the pain has settled that the movement is possible to increase and to stretch out and gets better. So normally what you see is someone's left stiff but isn't as painful anymore. So if you're not stiff anymore but you're still painful, I think a reevaluation to see, was there something else underlying that's persisting? I saw somebody just like that today who had, a very small little rotator cuff tear. It didn't need surgery, but it was still causing some inflammation in that space above the rotator cuff, what we call the subacromial space, even though their movement from the frozen shoulder had gotten better. So I think, if in that situation where there's still pain, but the movement's gotten much better, I would say go back and reevaluate, with either your physio or with a shoulder specialist and see, is it truly frozen shoulder? Is it something else?
Okay, lovely. Galliana has messaged. She said she's arthritis in her left shoulder from unknown reasons. She's 31 and she's had pain for more than 3 years. It's getting worse. Is it treatable or is it a lifelong problem?
It's certainly treatable. It's one of the big challenges in the specialty of shoulder care is arthritis, now true arthritis of the actual ball and socket joint in a young patient, because it's rare, but when it does present, it is treatable, and there are lots of things we can do in terms of pain management. You can have a shoulder replacement at a young age, and certainly we've done it in some situations, people with, aggressive rheumatoid arthritis type things. But the problem with it is that the shoulder replacements, we know they last pretty well for 15 years, 20 years. So if you have a shoulder replacement in your 30s, you're going to be looking at a revision, and also younger patients will tend to be that bit more active and be a bit harder on it, because you've got such bad pain from the arthritis, and then you feel great when we do a replacement and you sort of overdo it. So somebody that age, we would try and hold off as long as possible from doing a replacement, or we might, do another type of surgery if the arthritis was mild to moderate, where we do a keyhole surgery. But I suppose the answer to the question is yes, it's treatable. You don't have to live with it, but the options will be dictated by the severity of the arthritis and your age.
Okay, lovely. Laura asks, what is the difference between a labral repair surgery and shoulder stabilization?
So they kind of fall into the same category, where a labral repair is one type of shoulder stabilization surgery. So the labrum is a cartilage bumper around the socket of the shoulder that contributes to the stability of the shoulder. And when you dislocate the shoulder, the labrum almost always tears. If you've done no other damage to the shoulder and it's purely just a labral tear, you may be able to just have a keyhole surgery to repair the labrum and stabilize your shoulder that way. If you play a collision sport like rugby, Gaelic football, hurling, or if there's a bit more damage to the shoulder, in addition to your labral tear, if you've got some bony damage, so the front of the socket, the bone can get worn down, or the back of the ball, as the shoulder sort of comes out, the back of the ball hits the front of the socket and can have a dividend. Sometimes repairing the labrum won't be enough on its own to make that shoulder stable. So then we do other types of stabilization surgeries that often are open, sometimes using a bone block at the front of the socket. So a labral repair is one type of shoulder stabilization surgery, but there are a few different types depending on the situation.
Okay, thanks. As Ollie has also asked, does a rotator cuff always require surgery, or can it be healed through physio alone?
So it depends on the rotator cuff tear. Rotator cuff tendons don't have a good blood supply, so they will not structurally heal on their own. However, you don't necessarily need them to heal, because there are 4 rotator cuff tendons. The one over the top is the one that we most commonly see tears in, and a shoulder can function well even without that tendon. The shoulder can function well with the other 3 or even 2. If you have the one in the front and the one in the very back still working, you have what we call a balanced force couple. So in some patients, they can compensate. Now, in a younger patient, we wouldn't recommend that. If there's a large tear, we would err towards, the side of surgery and fixing it, because those tears can progress and cause trouble later on. Whereas in somebody who's older, that's less likely to happen, or if it does happen, we can use a replacement type operation. If somebody has a very small rotator cuff tear, it doesn't necessarily need surgical repair. It may get better with physiotherapy. It may settle down with anti-inflammatories and an injection. It won't heal because it won't reattach itself to the bone, but it may become asymptomatic. And in terms of small degenerative tears, if we took an MRI scan of everybody's shoulders aged over the age of 65, about half the population would have rotator cuff tears to some degree, and not everybody would be symptomatic. And when we as shoulder specialists talk about rotator cuff tears, we're thinking about full thickness tears, whereas a lot of times you'll see on MRI reports mentions of tears, but they'll be partial tears and tendinosis and that, and those don't really count as tears. They're not actual real tears. They're more just wear of the tendon, which is normal with age. So there's a broad spectrum of what people can mean by the term rotator cuff tear, and certainly not all of those things need surgery.
Okay, thank you. So Anne-Marie here has asked for, with a frozen shoulder following inflamed joint, can we start exercise rehab if inflammation has decreased and only comes back occasionally? My concern is with muscle wasting. I'm in my 50s.
Yeah, I think with frozen shoulder, the thing is when it's in that earlier, really angry, inflamed stage, you don't want to do anything that's going to make it more angry and therefore take longer to settle down. So what we usually do is just use some really gentle stretches, because the main concern is to get your movement back. You'll always be able to work on strength later. And if you start kind of strengthening and worrying about getting your muscles back while the shoulder's still stiff, you may not ever kind of stretch out enough to get all the motion back. So we would always start with some stretches first, and certainly you can start that once you feel comfortable enough to. We would always say when the shoulder is very sore that we kind of have people stay just within that kind of up to 5 out of 10 discomfort. And that's where the injections come in as well. They help decrease the pain, allow you to stretch. On our shoulder website on dublinshoulder.com, we have under services some stiff shoulder videos, so you can actually kind of use those to do your stretches. If you're starting to get more range of motion and you're not very painful, then it is okay to start, looking towards a little bit of strength work as well. But I think until you have more normal motion and more comfortable motion, the priority is the range of motion or stretching work rather than any resistance work with bands or weights.
Okay, Sheila, I've dislocated my shoulder 3 times in the last year, having physio, but very wary of the whole time. What do you think I should do long term?
I think if you've had 3 dislocations, then, it's very likely that there is damage to the inside of the shoulder, the labrum that we were just talking about, and possibly some of the bony structures that are, leading to it being more likely to dislocate and easier to dislocate as it goes on. And so I think that in that situation, it would be a good idea to see a shoulder specialist and have a special type of scan called an MR arthrogram or a CT arthrogram, which is a scan, either an MRI or CT scan, but where they put dye in your shoulder where we can see those structures better. I think after 3 dislocations, it's worth, at least looking at that imaging, talking to a shoulder specialist and looking at the options, which, may well include surgery at that point.
Okay, lovely. And last one now is how long typically for a frozen shoulder recovery without surgery?
So most frozen shoulders don't have surgery. Yeah. Most of them we treat without surgery. And how long it takes can vary. If you do nothing at all with a frozen shoulder, theoretically it will burn out itself. So the whole process will be that the inflammation in the capsule will eventually die down. And without any intervention, that can take 2 or 3 years to happen. The idea of treating it with anti-inflammatories or injections or even sometimes steroid tablets is to shorten the time until it goes away, and particularly to shorten that painful phase, which is the most miserable time for people when they're awake at night with it. And so a lot of times when we do injections, it can kind of shorten that painful phase that within sort of 6 weeks or so after an injection, or maybe a second set of injections at 4 weeks, 6 weeks later, the pain is starting to decrease. It varies how soon people regain their full range of motion. Probably on average, maybe 4 or 5 months after we start treating it. And some people, remember, have had symptoms for a long time before they come. Some people have had symptoms for a shorter time. So it is variable. I think the pain relief is probably quite consistent with the injections. For most people, within 6 or 8 weeks of the first injection, their pain is more or less gone. The movement varies person to person, but most people aren't as upset by the bit of stiffness as it's working its way out once they can get a night's sleep and the pain has settled. But I suppose the short answer is it can vary, but without any treatment at all, you could be looking at up to 2 or 3 years. And only a very small minority of people don't get better with injections and stretching and end up needing to consider surgery.
Ruth, thanks very much for joining us tonight.